Hey everybody, I'm your four-eyed professor, Chris Levens, and I'm super excited to talk to you today. Our roll call is for new and experienced ODs, optometry students, and even those just interested in this profession. We'll cover a number of topics together, and I'll help you see them through a professor's eyes. Please take your seats. School's in session. Thanks, everybody, for coming back to the podcast. Happy holidays. We are going to be talking today about a new emerging technology that probably many of you have not had your hands on yet, which is Heidelberg's Anterior segment OCT technology, which really does offer us some capabilities that we really haven't had in our hands before. And so I am going to be welcoming to the stage now Dr. Brooke Messer. Brooke, thanks for joining us. Happy holidays.
Happy holidays to you. Thanks for inviting me to chat with you today.
I love it. So before we dive into this, please address the audience and tell us all a little bit about yourself.
Yeah. Hi, everyone. My name is Dr. Brooke Messer. I'm an optometrist, and I practice in West Fargo, North Dakota at Vance Thompson Vision. We're a large multi-site OD-MD clinic. And so my typical day-to-day includes evals of all kinds, from corneal evaluations, glaucoma evaluations, cataract evaluations, all sorts of anterior segment ocular disease. But I also have a passion and a long background in specialty contact lenses. So I fit a lot of scleral lenses, orthokeratology, and things like that. So that's kind of where my variety of interests lie. And so never a boring day at the practice, with lots of, types of patients that we see, from pathology to fun contact lenses. And we also have a residency too. So that keeps things interesting, keeps me on my toes.
Undoubtedly. And given that we're chatting early in 2025, is it pretty chilly up there in the northern part of the United States or southern Canada, depending on your perspective?
Yeah. We had a nice white Christmas. I was at my parents' in Western North Dakota, and they have some good snow out there. And then in Fargo here, we're just chilly. So we're hovering around 0 today.
Yeah, it's chilly. All right. Okay. So Heidelberg's Anterior technology. How did your practice go about bringing this on day to day? And, what's been your experience thus far and your utilization day to day with it?
Yeah. So we decided that we wanted something that could help us image more of the cornea with an anterior segment OCT. A lot of the combined OCTs where you have posterior and anterior segment with just an added lens, you get like 8mm scans, kind of half the cornea. And then you kind of have to patch things together to get a full look at the anterior segment, where the Anterior gives us we can get a 16mm scan, or actually 16.5. So we can get, the entire anterior chamber. And we were initially wanting it to evaluate things like, good attachment of a DMEC to the posterior cornea, evaluating like how deep corneal opacities go into the cornea and things like that, at just a really high resolution. And so we, looked around and decided on the Anterior because of the images are just so clean and clear. And it's very, very hands-on friendly. So, there really you don't need much training to navigate the platform from a technician standpoint. It's really quite point and shoot. It tells you when it's ready. And so our technicians really love it. And so again, we primarily use it to image cornea, anterior chamber depth, angles, things like that.
So I'm glad you mentioned that.
Inspiration for getting it.
Let's touch on one of the things that you just said, because some of the folks in the audience today may have seen, or if not, please go look through the library. We did an episode on Mythbusters, and Heidelberg has long been known for having incredible image quality across all of their platforms. But there's been a prevailing myth, for whatever reason, that their devices are complicated to acquire high quality images, which in fact is absolutely not the case. I remember years ago being trained myself on the Heidelberg Spectralis, and it was within minutes I was acquiring high quality images, if not less. It was within my first 3 scans. And so I'm glad that you mentioned that. So in terms of time frame, delivery into your office, setup, installation, how much training did it take for your technicians to really feel confident in acquiring high quality images?
Yeah, so we usually divide it up into like lead trainers. So they really know the ins and
Okay,
outs, like
right,
all the troubleshooting. So they probably spent like a half a day with the getting it installed, getting it on the network, all that kind of jazz with the technical side of things. And then
right.
they went through the formal training, and then they kind of sat in on each small group training as our technicians rotated through. So
Mhm.
it really wasn't that long at all. And people just kind of bumped in, took a scan. There's 4 different modules on the Anterion to capture different types of images. And they took 1 or 2 on each module and then left. And there's been not really much for questions since. When it comes to, we're seeing patients for an evaluation, and I decide, okay, I think this patient needs a pentacam. I think this patient needs a visual field, or this patient
Right.
needs an Anterion. There's never like a shortage of hands being like, oh, I'll take that Anterion, because it's just, again, our technicians really like it. They find it so easy. And the patients actually find it pretty easy too. There's like no bright lights to look at. Certainly they're in like a chin and forehead rest, just like most instrumentation, but they don't have to like keep their eye open for a really long period of time and those types of things. So it's pretty pleasant on both sides of the instrument.
I love it. So you
Mhm.
mentioned the 4 module choices. Could you walk us through all 4 of those and when you pick one versus another for different patient types?
Yeah, so there's a metrics app, and that's what's going to give you, it basically measures everything in the anterior chamber. So it can give you pachymetry, anterior chamber depth, lens thickness, angles, kind of all the things across an anterior chamber for all of those measurements. And so we would primarily use that for glaucoma assessments if we were curious about the angle, in addition to gonioscopy. We would use it for like ICL planning. And I use that on my scleral lens patients too, because I can take a little, under the metrics app, you can take a little calipers, and I could go and measure scleral lens vault at various points if I want to know mid-periphery or central vault and that kind of thing. So I do use the metrics app fairly often with my contact lenses. And then they have a cornea app. So this is what we would use with our keratoconus, ectasia, RK type patients. And it gives you basically what a tomographer would give you. So it can give you anterior float or anterior sagittal depth readings. It can give you the posterior corneal findings. It would give you a power map or an axial map, something very similar where you would get like a 4-map refractive output on the pentacam. It can give you something very similar. And so sometimes if we have a corneal opacity or something where we get measurements on the pentacam, we'll also back it up with the Anterion and do the same measurements if we're trying to decide, is this one where we need to do some extra things to make sure it's safe to do corneal cross-linking?
Hmm.
Do we trust the measurements because of a scar and just, get more information? Or if we feel like a patient's changing, but we don't quite get the measurements we want to validate cross-linking on one instrument, we'll try it on the Anterion as well, just to see if we can find the numbers that we're looking for to help the patient get the treatment that they need. And then we have, so metrics, cornea, imaging. The imaging app is the
Hmm.
one that's fully customizable. So you can do raster scans, radial scans. You can go really wide. You can go very focal, magnified. You can add many, many scans. So if you wanted very, very dense raster across a large area, you could do that. So there's, with the imaging one, you can basically do whatever you want to capture it, and gives you a lot of information. And so we have 3 custom scans set up for our DMEC patients or scleral lens patients, and I just tell them, I need an Anterion imaging custom 3, and then they know what to take. And so it's quite easy for my technicians to interpret what the doctors are looking for and get those patients scanned rather quickly. The last module is for cataract surgery planning. We don't have that module because our current biometer connects to our surgery center, so everything is like very
Sure.
swift. But it can be also used for cataract planning, for biometry and things like that.
So you have a lot of technology at your fingertips of
Mhm.
various brands in your office. Do you typically, as I think you mentioned on certain patients, you may take a pentacam and an Anterion both.
Yes.
Are you typically marrying technologies together, or has the Anterion replaced some of your other older technologies?
Um, the Anterion definitely gives us, when it comes to imaging the cornea, we use it so much. In fact, I kind of prefer it for corneal opacities and corneal scars, because then I
Hmm.
can get the Anterion image and the corneal curvature findings at the same time. So not only do I get the image, but I also get what I would look for to monitor, an ulcer or a monitor a ectasia if I wanted to. If I felt like they had a scar and monitoring the ectasia, I could monitor both with one scan versus getting an anterior segment OCT with our previous device to look at the scar and then take them over to the pentacam. So I would say that we still run pentacam because of its gold standard on most of our KC patients.
Sure.
But if you didn't have a pentacam, it would certainly provide everything that you needed to monitor this patient, because it really does give some great outputs on corneal findings.
Got it. Have you had any patients in which, now that you have this technology, being able to employ it, with this image quality, and as you mentioned, it's pretty wide field anterior seg image, that you maybe have managed differently or picked up something different that you might have missed in the past without it?
Yeah, I think some of the neat things that we like to use it for is when we're worried about something like UGH or syndrome, or where we're worried about like some sort of pupillary block, because you can get, that deep into the anterior chamber.
Right.
And like we had a case of aqueous misdirection. So we could actually
Hmm.
see the shift of the IOL after doing the YEG laser to open up the anterior hyaloid face, or whatever you want to call it, that you could actually see the IOL dip and the iris fall back, both on imaging, to accompany the slit lamp. And so that's been really nice to have in a glaucoma clinic where, our provider is one of the best, or one of the most well-trained glaucoma specialists in our region. Being in North Dakota, the specialists are spread out. So we're probably
Sure.
2.5 to 4 hours away from our next glaucoma specialist who could do a tube-like surgery. So we do get kind of the worst of the worst when it comes to these traumatic cases and being able to image that entire anterior chamber. So rather than having to rely on like a slit lamp camera to see depth, we can actually have that to really provide like, how is the anatomy changing for better, for worse, as we're treating these patients. So it just really gives us another look at and kind of validates what we're planning and if our treatments are working for those types of cases.
What about your utilization? How often do you think you're sending patients to obtain images on the Anterior per day?
Gosh, I bet between our 3 optometrists seeing patients, I bet we have 20 scans a day. It's just a lot. Yeah, it's
That is a lot.
20, 25 times a day. It's getting used for various things. And again, there's just so many uses. And it's one of those things that the more you use it, the more you find it applicable and the more uses you have. Because again, we have a variety of patients. If we were just a cornea clinic, I think we would use it even more. But a lot of our
Right.
glaucoma patients and pretty much all of our cornea patients are getting some sort of Anterior scan.
Sure.
Mhm.
So what about the future? How, how might you predict the future to evolve with technologies like this in its current form, and maybe predicting where it might go in the next few years in future forms that maybe you and others might be able to utilize things like this?
Yeah, well, thankfully, the future is now, because they just got their epithelial mapping module, or their epithelial mapping addition to the cornea module added. It
Right.
was FDA approved earlier this month. And I guess the software updates are coming out in later January. So I am
Hmm.
really looking forward to that. We've been waiting for the epithelial mapping to monitor our keratoconus patients and other refractive surgery patients to just, again, help us best plan their care. So we're really excited about the epithelial mapping coming through here soon. In the future, I just see more ability to customize, we've talked to the Heidelberg team about, could we map more things with scleral lenses, more things that
Hmm.
would be applicable to an optometry office versus
Sure.
maybe an ophthalmology specialist type clinic. I do think that there's opportunity to make it really applicable. I think it's already a good tool for an optometry office because it can give you the anterior segment imaging, it can give you the angle imaging, in addition to pentacam tomography type scans. So you can have it all in one instrument versus multiple. So I already think it could definitely be applicable in a medical optometry practice. But those additions that could maybe be used in contact lenses would also make it even more beneficial in an optometry clinic.
So talk to us a little bit more about the angle imaging capabilities, because
Mhm.
I think if so some of our colleagues who are attending to the podcast today, who are big contact lens practitioners and scleral lenses, I think they would quickly understand how this technology could be utilized. I think patients who are sorry, colleagues who are in anterior seg practices where corneal dystrophies, diseases, and scars and ulcers, what have
Mhm.
you, I think they could understand it as well. But now, as we pivot more into our glaucoma practices, where anterior chamber abnormalities and angle idiosyncrasies are there, but a lot of times overlooked. And sometimes can be very difficult to ascertain even via high quality gonioscopy. And so,
Mhm.
how do you really see this being embraced?
First off, it's really fast because you can
Mm,
just do, the metrics app. It would scan the entire chamber very quickly. It would probably take about 3 to 4 seconds to get the
mm,
entire chamber. And then I believe they are working on like automatic angle detection and measurement. Right now, you just have to go in and mark the scleral spur, and then it'll
sure.
calculate the measurement for you. And you can manually create the angle with the caliper tools to kind of double check it, or if you mark it, then again, the instrument will automatically calculate the angle for you. And so I think it can be reassuring in a clinic where maybe you don't do gonioscopy that often and you just want a little reassurance that, hey, these angles are in normal range, or, you have maybe an older patient with a thickening lens over time and you want to be able to, maybe they're a low to moderate glaucoma suspect, and you just kind of want to monitor that angle over time. Those would be really easy ways to compare, because you can then go into a multiple display and you can pull up old versus new, and it can even show. To be honest, I would guess it can do the same. Like on a cornea scan, you can do new versus old, and it can show you a difference map.
Hmm.
But you could put on the metrics one, you could definitely do. You could see the old one and see the new one, and then physically measure the differences between the two.
Yeah. I love it. So,
Yeah.
what excites me the most about this is I flash back mentally to when OCT technology first came about. So, imaging the optic nerve, and then subsequent to that to the retina, and then uh, trying to go deeper into the choroid. That has all now become relative standard of care within the past decade or so. And anterior segment OCT technology has come on later, but I would say certainly within the next 5 to 10 years, we can see this across all practices, and utilized across all practices. It's just the interseg came on a little bit later, so it's lagging behind a bit. But now that the Anterion is showing us widest field, as well as incredible image quality, it's allowing us to visualize the anterior segment in a way that we just have never been able to do at all before.
It's pretty amazing. You think about the thickness of a DMEC tissue, right? So it's the
Hmm.
thickness of the endothelium plus one cell layer. So that what ends up being like 7 microns thick or whatever it is. It's pretty darn thin. And if there's a little, area of detachment from between the DMEC graft and the posterior cornea, I mean, you can see it. I even have one where the graft kind of curled up backwards on itself, and it looks just like a perfect curly Q. I mean, it has such great ability to pick up those fine things. And so again, if we have, a corneal graft that it's not recovering well, or there's some focal edema, it can scan right through that hazy cornea and pick up that graft detachment or whatever's going on. Maybe there's some, um, uh, some snickiae somewhere with the iris, or
Hmm.
just anything. It can go in there and it can see that well, even through a moderately hazy cornea. So it's very
Yeah, for
helpful
sure.
in trying to troubleshoot when you maybe can't see what's behind the hazy cornea.
Yeah. When I look towards the future, I'll share a quick story with you, as well as some experimenting we've done recently with the Anterion. I think it was like 2015 or so. I was lecturing in Australia, and one of the topics came about of meibomian gland disease and dysfunction. And I had mentioned that right around that time, the first meibographers had come to market, and I had seen some cases in which it looked like glands that were previously truncated or missing all of a sudden came back after therapy. And I did follow that up with, I don't know if they really have improved, or maybe the imaging was misleading us in a way that they really weren't as truncated or weren't missing per se. Well, since then, so in the last 10 years, not a month goes because that presentation was then put into a manuscript and published in in Australia, New Zealand. Not a month goes by that someone doesn't reach out to me has horrible dry eye or active
Mhm.
surface disease and has been told they have problems with their meibomian glands, either being lost, atrophy, truncated, what have you, and say, hey, what did you do to restore these? And still today, now 10 years later, have no proof of exactly what's going on. But there's this hanging thought in my head thinking that, well, maybe meibography being a two-dimensional scan is just missing the way a meibomian gland may course up and
Mhm.
downward. And maybe
Mhm.
it's just not as bad as we initially think. So Joey Hadfield from Heidelberg brought an Anterion over to us, and Laurel Kelly, a colleague of mine, had brought in some patients whose meibography looks awfully bad. And then with the Anterion, we actually imaged through the epidermis after everting the lids, and looked at the meibomian glands in depth. And we're either one of the first, if not the first, to ever do that.
Yeah, that's really
And the
cool.
images are very compelling, suggesting that maybe meibography is misleading us. And even antiquated use of a transilluminator, if the light's not positioned a certain way or the meibomian
Mhm.
glands are coursing vertically through the tissue, it can be misleading, and maybe patients aren't as bad off as they appear. So
Yeah.
it's just things like that, that thinking outside the box with some creativity it might allow us to manage the ocular surface and the anterior segment in a way, a newfound way rather, that we just haven't been able to before.
Yeah, it would make sense that, we've all seen the tortuosity of vessels going side to side, like, why can't they
Sure.
go forward and backward? And perhaps when they're at, initial state, maybe they're slightly more edematous, where there's just a slight, positioning in the anterior to posterior placement in the lid, and then you reduce some inflammation, things like that, and then maybe that vertical plane becomes a little shallower, and then, oh, there they are, the glands are back. So I think that we had I had listened to you share that story at Academy this year, and I reminded myself I needed to go back and do it at the clinic, but I haven't tried it yet. So that's another
Yeah,
reminder number two, that now I need to
get
go
on
image
it.
some glands, because we have a meibographer, in another instrument, and so I need to do that next time I have a pore scan. So
You got it. Yeah,
yeah,
I would love to hear your thoughts. Maybe we talk about that on a future
the
podcast.
next one, yeah, next dry eye podcast, we'll talk about the Anterior again.
Well, in closing, I'm going to let you share some closing thoughts and words of advice to our attendees as well. But I'm going to put on everybody's to-do list in 2025. All of us need continuing education credits. And for the most part, almost every big meeting in which we can attain those credits, there's an exhibit hall. And Heidelberg's present at quite a few of those big meetings. A picture is worth 1,000 words. And we can talk and talk and talk about how this technology is different and special and unique. But until you actually see it firsthand on a computer monitor in front of you, sometimes it's hard to appreciate the differentiation that this technology is bringing to us compared to others. So I'm asking everyone in attendance today in a meeting in this coming year to stop by Heidelberg's booth and look at the Anterion firsthand and get your own impression about what this might deliver to you, your employees, to acquire images, as well as your practice, and most importantly, your patients. Because I think everybody can really benefit from something that's so special like this.
Yeah, I agree. I think if you're in a practice where you fit a lot of specialty contact lenses, and then by
Mhm.
nature you're monitoring a lot of patients with corneal ectasia, scars, transplants, things like that. If you're in a clinic where maybe you're a little bit more rural and you see a lot of trauma, where you're kind of that gatekeeper to, send somebody to the ER versus, the next big metro to ophthalmology, and any place where there's a decent amount of ocular disease and glaucoma management. I think those would be three, big types of practices that would benefit from having the Anterion. And so if you're looking for that next new piece of technology in 2025, I think it should be on the list to consider.
Fantastic. Thanks everybody again for participating and attending to the cast today. If you have any questions, email me. and I'd be happy to respond. Also, if you have any ideas about other topics at hand like this one, please don't hesitate to reach out. Thanks, everybody. And again, Happy New Year.
Class is ended for today, and we have no exams or grades approaching. Please email me at foureyeedprofessor@gmail.com if there are topics that you would like to hear and see through a professor's eyes.